Hi, everyone.
Hi, good morning, Tuba.
Thanks for sending the link.
Start.
Yeah. Mahesh, I think another minute. People are just joining. One second, we
Okay.
can wait for a minute. Yeah.
It's 8:05.
Yeah, no, it's 8:04. We start in 1 minute.
Yes. Good evening, everyone. I welcome you all for this first webinar of year 2025. And we start with a topic on genetics in autism spectrum disorder. I request our President Shafali ma'am to introduce the speaker for today and the experts for today's session. Over to you.
Thank you. Happy New Year to all, and welcome you to this webinar on a very, very important topic and very interesting and very close to my heart on genetics of autism spectrum disorder. And Asmita, can I have the slides, please? And we have a wonderful speaker today, Professor Christine, who's he's a professor in the Department of Child and Adolescent Psychiatry, Psychomatics and Psychotherapy, Autism Research and Intervention Center of Excellence, University Hospital Frankfurt in Germany. And she concentrates on child and adolescent mental disorders, particularly autism spectrum disorders, conduct disorders, and many more. And she serves as the chairwoman of the steering group of AWMF S3 guidelines on autism spectrum disorders, and as member of many, many scientific advisory boards, and a wonderful professional and a wonderful orator. Thank you, Professor Christine, for joining. And experts, we have Professor Hassan Tegul, needs no introduction, a dear friend, a very prominent pediatric neurologist from Turkey, and all people here know him very well. Thanks, Dr. Professor Hassan, for joining. And then we have Dr. Tuba Rashid Khan. And thanks for joining, Tuba, pediatric neurologist at the Autism Spectrum Center, Boston Children's Hospital, and is recipient of the Futures in Neurology Research Award by the American Academy of Neurology, and author of inspiring children's book, My Friend Adam. And we have a dear friend, Dr. Vinod Skari and Dr. Moinak Banerjee. Can I have the next slide, please, Asmita? Dr. Moinak Banerjee is a very senior scientist, Human Molecular Genetics Lab, Rajiv Gandhi Center for Biotechnology, Thiruvananthapuram, Kerala, in India. And he's a past president of Indian Society of Human Genetics and vice president, Association of DNA Fingerprinting and Allied Technologies. He's a professional par excellence. Thanks, Dr. Moinak, for joining. And Dr. Vinod Skaria, who's a very dear friend, a collaborator, and right now he's in Karinkosa University. He's joined recently and moved to Bangalore. And for the moderation, we will be having Dr. Mahesh Kamate, who's our first DM pediatric neurology when we started in 2004. So, and now he's himself started a DM pediatric neurology program in Belgaum. Thank you, Mahesh, for moderating. Over to you.
Okay. Without much ado, I request our speaker, Professor Christine ma'am, to share slides and do the presentation. Over to you.
Thank you. I just have a look. So, can you see it?
Yeah, we can see the slides.
Yeah, perfect. So, yeah, thank you very much for inviting me to this really exciting discussion round. Maybe I have to say I'm a child psychiatrist, so I will also talk a bit about the clinical phenotype of autism spectrum disorders, as I realize that pediatric neurologists very often see the children with very severe phenotypes, and the children with a bit less severe phenotypes, they are often not seen by pediatric neurologists. And maybe just to alert everyone of the spectrum of autism spectrum disorder and neurodevelopmental disorders, I have also included a few informations on the clinical phenotype. Here you see my biosketch again, and my conflicts of interests. Yeah, and when we now start, When you are a child neurologist or a child and adolescent psychiatrist, it's always the question, you see a child with some kind of disorder. We as child psychiatrists, of course, see children with mental disorders. And we ask the question, do we have to plan a genetics assessment? And if yes, why do we need to have this, and what additional clinical value can we achieve through this assessment? When you are a human geneticist, you usually have a child with a diagnosis, or maybe the child has some kind of disabilities, and you then have will have provided some kind of a genetic disorder diagnosis. And your question is more, is it important to do a developmental assessment or a psychiatric assessment? Does this child have a risk for an additional mental disorder or for a neurodevelopmental disorder? And what diagnostic measures would be interesting to like, for example, as a screening instrument, if the child has some additional mental problems? So we have very different clinical questions in regard to the genetics of neurodevelopmental disorders in general, and in regard to the genetics of autism spectrum disorder. And I just wanted to talk a bit about the phenotype. So you know probably ICD-11, and I don't know if you do diagnosis according to the ICD-11 in India. We are probably outside of the US, most countries will do the diagnosis according to ICD-10 or ICD-11. And in Germany, we are still with ICD-10, but ICD-11 is really quite a good classification, I think. And you can look that up on the WHO server. It's no problem to find that. And there you can see the classification of neurodevelopmental disorders, and you see that all the children with any kind of developmental disorders, they are classified under this major heading, and you include here disorders of intellectual development, speech and language disorders, autism spectrum disorder, developmental learning disorder, motor coordination disorder, and ADHD, and also stereotype movement disorder. And these kinds of disorders you will see in quite many children, also with genetic syndromes, and these neurodevelopmental disorders are characterized by a strong genetic background. This is one of the overarching commonalities of these neurodevelopmental disorders. When you look at normative development, it's clear that neurodevelopmental disorders, these children, they are somehow outside the normative development, either in regard to cognition, either in regard to adaptive or any other behavior, or in regard to language or emotion regulation or any other mental capabilities. And a bit, you have to think about neurodevelopmental disorders a bit similar, like growth curves. So the children who may have a clinical problem, they are just outside of the typical development in this specific area. And therefore, this approach, which you have for, like, for example, research on growth problems, is quite similar also for neurodevelopmental problems. The other issue about autism spectrum disorder and neurodevelopmental disorders in general is that you rarely have just one disorder. Yeah, you very often encounter children with several of these aspects, and I just have shown you the round here. So you very often have children with autism spectrum disorder and intellectual disability and speech and language disorder, very often plus oppositional defiant disorder, very often plus anxiety, very often plus ADHD. So you have all these different aspects of mental and neurodevelopmental aspects, and each child has a different, like, phenotypic characteristics based on many of these aspects, and their sort of abilities, like, do they speak very fluently, or can they not speak at all? So you have quite diverse phenotypes in autism spectrum disorder, but these are the areas which are really important to look at in all children with autism spectrum disorder. And I think this is really important to know because very often we are just looking for language abilities or for intellectual abilities or for the genetic syndrome, but we don't see the full pattern of really abilities and also disabilities of these children. And I think this is really important because it's of course very important also for the cause of these disorders. For example, if a child also has a lot of anxiety or not, because you can treat that very effectively. And this is really important also for pediatric neurologists and also for human geneticists to know that it's important to look at these comorbidities because there is effective treatment. This is really very important, yeah. And also, of course, these phenotypes, they also explain a bit or tell you a bit about the genetic risk, which I will come to that later. Yeah, that's the main issue that especially for a good targeted intervention, you should really look at the entire broad phenotype of the comorbidities and the main disorder. For example, when you have a child with autism spectrum disorder, but it's the same if you have a child with intellectual disability, they also can suffer from additional ADHD or from additional anxiety disorders. So here it's a summary on the neurodevelopmental disorders and their specific etiology. And you see all of them have some genetic component, and many of them also have very strong prenatal components, like for example, alcohol exposition during pregnancy or viral infections during pregnancy or exposition to neurotoxic substances. So there is a really quite strong overlap of the risk factors for all of these disorders, and some are a bit more specific, some are less specific. For example, developmental motor coordination disorder, there seems to be more really strong prenatal risk factors, a bit less so genetic risk factors, but in general most often it's really an interaction of genetic predisposition and prenatal biological risk factors. And we know all that, for example, neurotoxic substances are increasing due to the industry and so on. For the etiology is also quite overlapping with the neurodevelopmental disorders. And here is this example for ADHD etiology, and you will probably know this paper. So we know we have a quite high heritability, and I'm talking about especially these genetics much more in detail, but we have to make clear or be aware that we have also gene-environment interaction, especially with prenatal risk factors. And these environmental factors here you have to list. It's really especially prenatally effective, which sort of these environmental effects increase or decrease the genetic risk in that sense, yeah. And what is also very important when you see the children, of course, the social environment can shape the course of these disorders. So, and you can even have, and you all know this, you can even have the same genetic risk factors, and then you have the polygenic genetic risk, which shapes this a bit. You have the environmental risk, but also, of course, the social environment, which can be helpful for the child or less helpful, and then you have either more severe phenotype or less severe phenotype. And I mean, this, especially the social environment, of course, is the area where you do interventions, because this is what you can change, yeah, usually. And of course, with the environment, you do some preventive things. But when a child has an autism diagnosis, you can just intervene on this area of social environment, and this is important, and you can do many things there. Yeah, but this is not the focus of my talk right now, but it's important to keep in mind that you don't end with a genetic diagnosis, but then you have to really plan the adequate interventions. I think this is really important from a clinical point of view when you are a child psychiatrist or also child neurologist. Yeah, the comorbidity is also, of course, combined, and and especially when you have a copy number variation, and we know that in the children with copy number variations, they have a high rate of other comorbidities. And here you see this. It's quite an older paper, but it's still worthwhile that we have all genetic risk factors which you know. So we have de novo variants, copy number variation, single nucleotide variation, inherited variation, polygenic risk, mosaic variants, syndromic disorders. We have all and larger karyotypic abnormalities. So we can find almost everything in autism spectrum disorders. And as a rule of thumb, you can always say, and human geneticists know that the bigger, for example, a copy number variation or, of course, a karyotypic abnormality is, the more severe is of course very often the disorder itself, but also the rate of comorbidity. And the microdeletions and microduplications are, of course, very frequent in autism. Just to let you know what we are working on, I'm showing you a bit of my of the people working in my department. So Professor Andreas Chiocchetti, he's the molecular geneticist and he's doing bioinformatics and molecular genetics. Christine Ecker, you may also know, she's a very well-known MRI person in autism research. She's doing brain imaging and genetics. And Nico Bast is doing eye tracking and also an early intervention together with me. And Denise Haslinger is looking into model cell models. And my specialty is more here really the behavioral phenotype and the developmental trajectories, but I know quite a bit about genetics. So that's why I'm giving the talk today. Yeah, so just to summarize the broad area of neurodevelopmental disorders, we have this a high rate of comorbidity, and we have also an overlapping and sometimes also distinct etiology. And what I have not really gone into, but what is of course the future research agenda is to find more homogeneous from the neurobiological background, more homogeneous subtypes across all the neurodevelopmental disorders to find more effective treatments. That's the kind of personalized intervention which I have mentioned here. And this is of course very relevant for the intervention itself, but also probably for the longitudinal course. And it's important, especially for parents and the affected individuals themselves, because not all the interventions are effective, which we have currently for these children. And therefore, genetics plays a strong role, I think, especially also in the question of, could it be a basis of future personalized intervention? Yeah, just to show you a bit about the diagnostic procedure. So this is ICD-11, and what we do usually, of course, we take the medical history, we do a developmental assessment, we ask about the care and learning environment and the history of the symptoms, of the core symptoms of the child. We look at the psychopathology, the additional, like anxiety, depression, ADHD, oppositional defiant problems, and so on. We do a medical examination. We do a standardized developmental testing, including language, and also, of course, questionnaires where we do look at psychopathology. And then, of course, you should also, of course, do a genetic exam. And for the phenotypic expression, we look into all these areas, somatic aspects, cognition and play, internalizing symptoms, externalizing symptoms, stereotype behavior, self-harm, social interaction abilities, because I think these are, especially when you do, for example, early intervention, but also later, it's important to know about these things, because you have to really select your intervention based on the pattern of behavior and abilities. And you have to be clear what you want to support more, and for what would you need medication. For example, when you have a comorbid ADHD, you would also take medication. And therefore, this is really important when you do the diagnosis. What is complicated is that you have a symptom overlap, cross-diagnostic symptoms. That's where we do a lot of research on. I think I'm not going into this into detail. These papers are all published, but this is what is complicated, and what currently when we do interventions, we really look more on the phenotype and the dimensional expression, and look and target specific symptoms and specific developmental aspects. What we are currently not able to do, and which will hopefully be the future. When we know about risk factors, they do not guide intervention currently, and that's actually the idea of personalized intervention, to include biological risk factors and genetic background into the intervention planning, especially when you look for medications and so on. But this is not a current routine care. Yeah, here you see that. So what is also the scientific background. So here on this phenotypic area, we have a lot of studies. On the etiological area, we don't have really studies on intervention, just on prognosis, prevention, course, and a bit on the moderators and mediators is also the focus of intervention, but not that much really. It's especially the phenotype, which and the disability, which you can study, which guides your intervention, which you do. Okay, now we are coming to the core aspects. What could be the aims of genetic testing during the diagnostic and therapeutic assessment when you have a child with autism spectrum disorder? I mean, the aims first, of course, is for the child itself. Does it profit from the genetic testing? And I would say, I mean, there needs to be more research, of course, but I think you can still find, when you have a genetic etiology, you can very often find some also somatic disorder risk, which you can then maybe prevent or treat early. For example, in Prader-Willi syndrome, you can give growth hormones and so on. So you will find quite a few symptoms or syndromes or also mutations sometimes, where you know, okay, this also increases the risk for an additional somatic disorder. And also, of course, you know that you find some findings where you have an increased for general mental disorders like 22q11 deletions and so on. So for the child itself, it's quite important to know his or her genetic background. Of course, the young children, they cannot do anything about it, but it's the parents, of course, they have to do something about it in the healthcare system. But it has some individual aspects why it's important also for the child to do a genetic diagnosis. Regarding the prognosis, we are currently not, in my opinion, in the scientific, or we don't know enough to say, okay, the genetic diagnosis can really tell us much about the prognosis beyond IQ and language abilities. Yeah, so when you know an IQ and the language abilities in a 10-year-old child with autism spectrum disorder, you will, of course, have very good markers for adults, maybe functionality, because we have quite good studies on that. But beyond IQ and language abilities, and especially also or also in addition some other mental disorders like anxiety, you will not gain much more information on the prognosis by genetic testing. So in regard to prognosis, I think genetic testing is not really relevant, individual prognosis, but of course it's very relevant for genetic counseling for the families, and all the human geneticists know that. And when you have a genetic finding in an affected child, of course it's much easier to think about and of course when you then also genotype the parents, or the siblings, you can say much more about a specific recurrence risk compared to to without a molecular genetic finding. Yeah, when you just do it, say the recurrence risk on the population-based level, it can vary strongly. Yeah, so on the population-based level, it's between 5 and 10% when you have a child with autism spectrum disorder. But if the child has Fragile X syndrome, you know that it's much higher, especially when the child will be a boy. Yeah. Therefore, it's also very relevant for genetic counseling to have an appropriate genetic testing. And the parental views on genetic testing are generally rather positive, but these are data, of course, from the US. I don't know about India. I guess in Germany, these data would look very different. German people are more critical about genetic testing, but I think probably in India and also in the UK, it's probably more like the US. And in the US, people really prefer testing the parents. Yeah, so these are the parents of children with autism spectrum disorder, and they prefer testing, and they also say they expect that they will find results which are relevant for the child and for the family as well. And also the same is the case in Norway. So also there, parents really prefer the testing, and in this study they were asked who should decide about this, and many parents wanted to take the decision themselves, not doctors, but more than the parents, but this obligation to know, so that you make the parents responsible, that they all agree to genetic testing. So in that sense, you have to know about your child because it's important for your child. People are more critical, so they do not want to be pressured into the genetic testing. But if they can decide themselves, and if they think it's rational, they are positive about genetic testing. And I think this is important because we, of course, want to have also an acceptability of the genetic tests we provide in the parents of children with autism spectrum disorder. And the usefulness is also quite there. And here, and you can, that's the benefit which the parents again in the US found, and moderately and very helpful was the majority for the question, did it explain something about the disorder of the child, and especially of course when they found some pathogenic variation which was clearly pathogenic for the child. When we now go into international clinical recommendations and guidelines, I have actually done a current internet search, but the latest one, which is international, is actually from 2020 in Genetics in Medicine. And that's the question, what kind of genetic testing should you do when you have a child with neurodevelopmental disorders? And they clearly say exome sequencing should be a first-tier clinical diagnostic test. This is actually not done in all countries. Maybe due to the costs, but they have come down quite a lot. But for example, in Germany, it's not being done. We do still microarray, but the recommendation since for the last 5 years is already to do exome sequencing, and this is sort of the statement, and this is also open access, so you can look that up if you want to look at these clinical guidelines. And in this study, it's quite a good study because they show the diagnostic yield when you do exome sequencing, and they also included all children with neurodevelopmental disorders, so and looked separately into children with autism spectrum disorder, intellectual disability, and ASD plus intellectual disability. And what you can see here is that when you just have autism but no intellectual disability, the yield of exome sequencing is not that high. So this is what I said about the variable phenotype. So of course you have like 50% of children with autism spectrum disorder who don't have an intellectual disability, and in these children you find less sort of single nucleotide polymorphisms where exome sequencing really helps you. But for the children with intellectual disability and autism and intellectual disability, the yield is much higher, yeah, and so especially in the children with autism and intellectual disability, it's recommended to do exome sequencing, yeah. In the children with just ASD without intellectual disability, probably it's not essentially necessary. But 16% is also some word, but it's not so much when you compare this with the children who also suffer from an intellectual disability. And according to this paper, these findings, when you had some findings based on the exome sequencing, they led to a change in clinical management in 30% of the children. So this is quite a bit. So, and I think this is a very important figure because this is also, of course, a clinical justification to do the genetic testing. And in 80%, it was really important for reproductive planning. So this is the genetic counseling aspect. And this is also really important when you think about why should I do genetic testing in children with autism spectrum disorder. And in these guidelines, they have like a flow, what you should do in children with intellectual disability and or with autism and with or without syndromic presentation. So these are the sort of three separating phenotypic aspects. So in all children, they recommend actually exome sequencing and CNV assessments. And CNV assessments is, you can do this either with based on bioinformatics and exome sequencing, but microarray is probably much better still to look for CNVs. And of course, if you find something, you stop. If you don't find something, you think about a chromosomal microarray. If a CNV analysis has not been done before, if you find something, then you stop. If not, you think about later when you have better sequencing facilities, or do a whole genome sequencing, and then you stop, or you do a reanalysis later. And what I think what you should also add, what is not mentioned here, you should of course also look at the sex chromosomes, because we know from other studies, for example from this review, that in autism we find quite many children also with sex chromosomal disorders like XYY syndrome or XX syndrome, especially XX syndrome in ADHD, but XYY in ADHD and also in autism spectrum disorder. You can see this here. When we now look at the copy number variations, which are also quite frequent, there is this one huge study in JAMA Psychiatry on the, I think it's on the UK Biobank. Oh no, sorry, I think it's on several biobanks. And here you can see the frequent copy number variations which are found in children with neurodevelopmental disorders, and that's here. It's the 2q13 deletion and duplication is more than 1%, and also the 15q11.2 deletion and duplication, and 15q13.3 duplication, and 16p13.11 duplication. So these are all over 1%, and so these are rather frequent, and at least for these CNVs, you should really genotype all the children. But you see that many more CNVs are found, but of course with a much lower frequency in this population. And these are just children with neurodevelopmental disorders. In addition, there's a really nice systematic review on the question of penetrance of these CNVs, because not all of these CNVs are highly penetrant. And in this study, they they said if a CNV is found frequently in cases and in controls, we think it's of low penetrance, even if it could be pathogenic, but it's of low penetrance. So we would not say it's essentially a cause of, for example, autism spectrum disorder. And when you look into this study, I just summarized here in this table the CNVs with high penetrance according to this paper, and you see they are quite more than before. So they are more rare CNVs, sometimes below 1% prevalence, but very highly penetrant CNVs. And these are the clear risk factors, for example, for autism, these CNVs when you find them. So it definitely is recommendable if you do a microarray on autism spectrum disorder to at least include these highly penetrant deletions and applications. Yeah, and I'm not going into detail. So if you are interested in also the genes which are covered by these CNVs, I think it's good to look really detailed into the literature, because they have also variable lengths and so on. And I think this is then really very detailed knowledge of human geneticists. But just as a take-home message, it's really important to look at CNVs in autism spectrum disorder, because many of them are highly penetrant, and they can very often explain the phenotype, and very often, in addition, they are not inherited. Yeah, they're just sort of present in the child itself, and this, of course, is really important for genetic counseling. So for the parents, it's very important to know if they also carry this CNV, and if they can really give this to a new child, or if the risk is very low, and if it's just the risk in this one specific child with the autism spectrum disorder, for example. So just to come back to our first slide, I think when we take together, of course, I think we definitely, as pediatric neurologists or child psychiatrists, if we have a child with a neurodevelopmental disorder, especially if it's also combined with an intellectual disability, so autism, but also ADHD plus intellectual disability, then of course you should do genetic testing and preferably microarray, CNV microarray plus sequencing. But also I remind the human geneticists and also pediatric neurologists that you should do really a broad phenotypic assessment, because this guides the parents in relation to interventions and what to focus on. This is really also very important for counseling and do psychoeducation for the parents, that you say, okay, this is the area you think there should the intervention focus on, because very often you cannot improve everything, but you try to support especially the things which are of most the highest problems of the child. For example, if there's an anxiety disorder, you should of course treat it. This is the summary of the recommendations for the geneticists, and this is just the repetition of the genetics in medicine. But what you can see here, and this is also in this paper, even by exome sequencing, but also by microarray, you can't always really find all the genetics risk factors which have been described for autism spectrum disorder. So if you don't find something with the exome sequencing in the CNV microarray, please think about, should I do whole genome sequencing? Should I do also a karyotypic assessment? Should I maybe look for a special inversions and so on? And this, of course, is based, and then, of course, you definitely need to have a good experienced clinical human geneticists with that. This, of course, also depends the presentation, the phenotypic presentation, because very often you have some additional somatic problems or some additional features, dysmorphic features, which may guide you into more specific and more detailed genetic analysis. And this is, and therefore it's really also important, besides doing the phenotypic assessment in relation to all the mental disorders and IQ and language, also look, of course, in the somatic conditions, because they can guide you with the genetic testing as well. This is very important. And I think maybe in a discussion, we can come back to that later, because we also have human geneticists in the discussion, which is really nice. Yeah, and for the translational research, just the outlook, I think what we need to have is, especially in the human genetics papers, we definitely need to have deep phenotyping, yeah, which means that we just cannot simply rely on, is there an autism, yes or no? This does not really mean much, neither for the intervention nor for the prognosis. We need to really look broadly into psychopathology, and we need to look broadly into additional somatic disorders and IQ, language, motor, and also toileting abilities. They are also very important for parents, that the children learn this, and also, of course, into adaptive behavior and into the specific abilities of the children, because many of them have very good abilities which need to be really also challenged and also valued and taken as resources to overcome other problems. And of course, we have to also address how is the social environment, how supportive can be the parents, how supportive can be the school and the classroom setting and so on, because this is really relevant also, of course, for the prognosis. And I think this definitely is important when you work clinically with children with autism spectrum disorder. And for the future of the research, I think, what I said at the start, and there's also really this nice paper on clinical translation of basic science into psychiatric genetics and also into psychiatric care. I think we definitely need to go the path into more personalized intervention, but of course we need to really have very large samples, and we need to really combine our samples. We also have, of course, need to have samples from all over the world to overcome the participation bias. Yeah, we know that we have the genetic background can differ. But also, of course, the socioeconomic background and so on. So we need to have really more large unbiased samples. And the other issue is that we have to include also into genetic testing in the future, in my opinion, the polygenic risk, because this is especially relevant for children without intellectual disability, but it will also, I'm sure, it also shapes the penetrance and the phenotypic expression in the children even with CNVs, because we know this, or even with SNVs. So if you have a mutation or a copy number variation, also the polygenic background is really important for the penetrance. We know this, for example, from breast cancer mutations and so on, and this definitely is to be expected for autism spectrum disorders as well. But we have far less studies on that worldwide. But also we have to think about the ethical challenges involved, and this is also really nicely discussed in this paper, which I can recommend for anyone who has access to it. I think this is really an interesting paper. Yeah, and I think here I'm done with my talk, and I think we now can have the discussions, and I'm open to any questions. Thank you very much for listening.
Thank you, Professor Christine, for the wonderful comprehensive talk on genetics of autism spectrum disorder. I'd like to invite comments from our experts on the talk today and on the topic also. I request Dr. Hasan Degul from Turkey to give his comments on the topic.
Oh, thank you, Mahesh. Thank you very much. Thank you, Professor Christine Freitag. I really enjoyed your presentation. I'm happy to see a lot of converging networks between my side and your side. I'm an epileptologist. When we look at the autism and epilepsy, sharing some different networks, some similar or the same biologic networks. When we started to genetic testing for epilepsy cases, we used the autism panel first. Then we developed our specific epilepsy panels with next sequencing technologies. We're happy today we have whole exome sequencing, whole genome sequencing, and then epigenetic studies. You clearly elaborated the implication of the utility of genetic testing for diagnostic perspective and the therapeutic perspective. My question about the future plan, do you think we use the genetic testing to define the different type of biologic networks for autism and comorbid disorders, epilepsy, or some movement disorders like that? Yes, today we have some subdivisions, some transcriptional factors, cellular pathways, and some synaptic channels, and then we try to define different kind of network analysis of the autistic brain as well as an epileptic brain. There is a converging networks between the two subclinical entities.
I think it's a bit easier actually in epilepsy, because in epilepsy, I mean, I'm not an epilepsy specialist, but Andreas Kluketti in my lab, he works also with an epilepsy group, and what in epilepsy it's in a way easier because you have many more single gene mutations which you know about like especially channels, Kalium or channels or whatever, and there you can of course also, and I think it's being done to do pharmacogenetic studies and to see which kind of children with which kind of epilepsy do really profit from which kind of medication. But I'm rather sure that we just don't have the right gene sets yet. But I think we should really definitely look into this because we see such variable results in psychiatric medication in children with autism spectrum disorder. So some of them, they really do have a high rate of adverse events, and others don't have that. And therefore, I think it's definitely worthwhile looking into these aspects to find better neurobiological networks, which, for example, can predict response or adverse events in pharmacotherapeutics. And in autism, there are a few studies on risperidone and adipositas, obesity. So some children with some genetic backgrounds, they have a higher risk of obesity. So there is a bit of research, but it's not about really, for example, also finding new medications. For example, you know, in autism, we have quite many frustrating randomized control trials on interventions. Like one of the last ones is, I think, bumetanide, but we have others like memantine and so on. So we have quite a few randomized studies, and it's a bit like also Fragile X. So you have a lot of good theories from animal models, and you think that should work in individuals with autism or with Fragile X syndrome and so on, and then it doesn't work. And I'm sure that this is about the polygenic background and additional genetic risk factors. And I think we need to find the subgroups who still gain from this kind of medication, because we have quite many medications, but they are not approved because we have such heterogeneous populations from the biological background that when you just look at the mean effects, it's not effective. But if you have a good biologically characterized group, they may even profit from some medication, which is not working across all the children. And I think this is the way where we have to go, but you need very large samples and very good data, especially on the medication and adverse events, to do these kinds of studies. And this is the major obstacle, really, because in the large databases we have just genetic information and phenotypic information, but no information, for example, on medication and so on. And that's one of the drawbacks in autism research. Yeah.
Thank you very much. Clear presentation.
Thank you. I'd like to invite a comment from Dr. Banerjee. Sir, you have to unmute
Yeah, good evening. It was a wonderful presentation, a complete overview of autism genetics, right from covering from CNVs to de novos and all. I was just curious, you have also mentioned about the acceptability in US versus some parts of Europe, but Germany, it is not considered, genetic testing to be not considered to be positive as a first line of action, right?
Yeah, it's a bit like that. Yeah.
So is it because of ethical concerns, or is it because of just about the scare of genetic testing and all?
I think it's about our history, because we had this eugenics history with the Nazi Germany, and I think that's still prevalent in the population. I'm rather sure. I would be curious to know how this is in India. Do people prefer genetic testing? Do they agree to that?
Dr. Shefali would be able to tell, but I would say that no. They don't
Yeah,
come.
they're fine. They're fine with it. No, but they're fine with it actually, Dr. Banerjee. Like Dr. Christian, they come when it's indicated, and when we say, I don't see any resistance when it is explained to them.
Oh, yeah, perfect. But this is good, because I think it's really helpful. Yeah.
So I had another query, is that how about is it when genetic testing is practiced in Germany, do you recommend only proband testing, or you actually recommend for the Trevor testing there?
Sorry, can you repeat this?
Is it only the proband testing? Is it that only the autistic child is to be tested, or the parents are also tested for
as
it?
well? So we first test the child, yeah. And I mean, we can do CNV testing with microarray, so this is being paid for also by the health insurance. And when you have an additional indication like intellectual disability, things like that, they even currently, because they do some kind of research on that, there's some funding that we can also have whole genome sequencing. And then if we find something in the child, also the parents are tested, exactly, for of course, for the genetic counseling. Yeah.
Yeah, because close to around 40 to 60% of the mutations that you tend to see are de novo in nature then.
Exactly.
So
exactly.
therefore, you will be missing out on those de novo mutations, which actually has functional implications with respect to the autism and even intellectual disability, and even for epilepsy is also there.
Mm-hmm.
So
yeah, this is true, definitely. Yeah.
Therefore, I would really recommend that if it is practice Trevor testing, where the parents and the proband is also tested together as the first line of testing there.
Professor Erol, you had your hand raised before we go to Tuba. You had your hand raised, Professor Erol. Thanks for joining from Turkey. Professor Erol.
Hello.
And then
Hello. Thank you for this meeting and the excellent lecture. I think that the only recommended investigation for autism is the genetic test. Is it true?
You mean from when you think about lab-based assessments?
Only recommended test for investigation for all autistic children is the genetic test. Is it true?
I'm in Germany in the guidelines. We recommend this, especially when you have, when the parents want to have this. It is recommended, definitely, but you don't need to have an EEG or an MRI or any other lab results. But of course, we also recommend that the entire phenotypic workup, which I was talking about. So this is of course also recommended, that you look into other mental disorders, and that you also look into intellectual and language development and so on. This is also recommended, but from the lab-based assessments, it's just genetics. It's entirely correct.
in our practice, in my practice, I usually start with karyotyping and microarray analysis if the child has dysmorphic findings like the DiGeorge syndrome or 15q duplication syndrome or Fragile syndrome or so on. But if the child did not has any dysmorphic findings, in that case, we usually start with the exome analysis, and we find some interesting cases with autism and some other comorbidities. These mutations are usually the de novo mutations. And in our country, the consanguineous marriage is high. So I want to realize that the inborn errors of metabolism, some of them are treatable disorders, should be included in the investigations of autism spectrum disorders in that cases. So what do you think about the first test, the first genetic test? This is my first questions. And the second one is in my practice, I am child neurologist. Sometimes we can see, especially the Rolandic spikes in autistic children. And sometimes this centrotemporal spike is so high, and the EEG abnormality is so high. In that case, when we start the anti-epileptic treatment with the proper anti-epileptic treatment, we see that the child autistic features also can be resolved. What do you think about the EEG abnormality, like the Rolandic syndrome and the autistic diseases? Thank you.
Just to comment on this, on the two aspects. So this inborn errors of metabolism, you're entirely right. I didn't talk about them because I forgot to say. So we in Germany we do have a postnatal screening for treatable metabolic disorders. Like we screen for 15 or 20 disorders. Of course, it's entirely true if you don't have a postnatal testing, like directly after the birth. If you don't have this testing in your country, of course you need to look into this much more. This is definitely clear, yeah, because there are many recessive disorders among them. Yeah, this is true. I mean, this is a very important recommendations you just said. Yeah, and the other one with the epilepsy. Yeah, the thing is, there is a big discussion, and I have actually, but this is quite some time ago, also worked in pediatric neurology for like 1.5 years, and we already had this discussion then. I mean, there is a consensus that you usually should not treat EEG abnormalities outside the continuous spike wave activity during sleep. I mean, this is being treated, but if you just have a Rolandic focus and no seizures, usually you don't treat it. So the problem is a bit, you have always some case reports where you give some anti-epileptic medications, even just with an EEG pattern, and the child improves, but because it's just a single case, you will never know if this child would have improved without the medication or not. And this is one of the big issues. And I personally don't know any really good studies who have looked into children with autism spectrum disorder and Rolandic spikes, which are quite many. You're entirely correct about this, but there is no really randomized controlled trial to say, okay, we randomize these children either into treatment or not to treatment or nothing. There's really not really much scientific evidence for that, and that's a huge problem, I think. Yeah, because case reports, you will always find cases who improve even no matter what you are doing. Yeah, single cases always improve. Yeah, and that therefore it's not really a scientific basis. Yeah, to recommend any treatment.
normally the normal children with Rolandic spice, we cannot use treatment. But in the case of patients with learning disabilities and deficient autism spectrum disorders, in that case, if the EEG abnormality is high, in that case, usually we can find a gene which is responsible for both the EEG abnormality and the autistic spectrum or learning disabilities or other comorbidities. And in that case, according to our practice, I can see some improvement in children's behavior and autistic findings. I want to say this, not the normal Rolandic spice. Rolandic spice spikes and autism spectrum disorders or learning disabilities or so other comorbidities.
Yeah, Professor,
And
you're
sometimes-
absolutely right.
Mhm.
Yeah,
Definitely, and
continue,
just
Christine,
coming
please.
back to Dr. Tegel, I mean, this is exactly what we have been talking about. If you have an SNV and you know that this is causing both autism and the epilepsy, and you have a clear-cut also neurobiological evidence that some medication is helpful, then of course you can use that. I mean, this is the kind of sort of also kind of personalized medicine we have to go for, yeah. But very, very often you don't have this situation. But of course, if you have that, I think that's a very good situation, yeah.
Just telling
Thank you.
Dr. Errol, we'll be coming up with another session on autism and epilepsy, the interface. That's a very interesting one. Tuba.
Yeah.
Tuba.
Hi, everybody. It was great meeting you and learning what your amazing lab is doing. I was thrilled to see that you had cited our department's study with Sid and Dr. Sahin as well. It's really interesting, right? Because 15 years back, you had these results that would come back as variants of unknown significance. And now we're seeing the journey pedal forward. So I won't say how many years ago, but when I was a med student, more than 10 years, oh gosh, no, I think 20 years ago. But anyway, chromosome 1 abnormalities was variants of unknown significance. And now we have such good data where we have 1q21.1 microduplication very much associated with autism spectrum disorders. And what this does with leading the path forward is now you have clinicians that are passionate about something can start these subspecialty clinics, and now these parents with the specific disorder have an avenue for now this subspecialist who's learning more and more of a specific disease. So for chromosome 9 disorder is associated with Kleefstra syndrome, now you have Kleefstra clinics popping up and providing great care. And then the thing that we don't know is how severe the child is gonna end up on the autism spectrum, right? I have kids with Kleefstra syndrome who present as very high functioning. And then I have kids who are quite severe. And on paper, the test is exactly the same in terms of its genetic analysis. So we're still in huge deficits, and I can give you a reason as your physician why your child is presenting this way, but I cannot be a future predictor of where your child is going to lie in terms of prognosis, right? The other thing is we can say, okay, this syndrome is associated with more cardiac anomalies than this or not, but how can we tell a child as family that, oh, I'm going to start this medication that can affect the heart and then not send them to the cardiac clinic, whether or not their genetic anomaly is associated with cardiac symptoms or not, right? So most of my kids, I still refer them to the cardiac clinic. I still like getting EKGs if they're on medicines that can affect the heart system. And I can't tell that this syndrome is going to do better with Abilify versus Risperdal. I can't tell that this kid with ADHD is going to do well with stimulants versus non-stimulant. So these are the two deficits that still lie in the landscape, even though it's really exciting about what we're learning, right? And then to a family that's kind of finish their family planning, right? This is a mom, she's at a certain age, she doesn't want more kids, or she physiologically cannot have more kids. To her, that's where some of the resistance may lie, right? What is the point of genetic testing at this stage in our family's life? So that's where I find more resistance, and I can't disrespect the family by saying, no, this genetic testing is important for our scientific knowledge, when it might not impact this family. Obviously, for the early families that still want to grow their families, that is very important. The other aspect of genetics is very exciting, right? So you have MECP2 and Rets. But what's exciting in terms of our genetic landscape is that we have learned that MECP2 duplication syndromes typically have better clinical phenotypes than your MECP2 deletions. So that's exciting too, that you can kind of give those answers to families. And I guarantee you, in the next 5 years, we won't be using the word terminology specific syndrome as much as we do now, as much as we do disorders. I think it's going to go into everything will be like a spectrum, because really everything is an umbrella, right? When you think about MECP2, now you have kids who have CDKL5 and you have kids who have FOXG1. And they all present clinically very similarly to patients who have Rets. So is it a spectrum, a Rett spectrum? And that's kind of where we're going as we learn more about genetics. So it was really exciting for me to hear. And I hope your lab does wonderfully in this coming new year as well.
Thank you.
Thank you, Dr. Subha. I request Professor Vinod Skaria to give his comments.
Thank you, Professor, for the fantastic and very, very clear talk. And thanks for emphasizing the importance of genetic testing in autism spectrum disorders. Now, I think I just one question. Now we have seen the evolution of genetic testing in autism spectrum disorders, right from looking at the chromosomal microarrays and now to exome sequencing. Do you think in the future this will all converge into whole genome sequencing as it becomes more cheaper and more affordable and more accessible? What are your thoughts on that, please?
Yeah, I think actually we should do whole genome sequencing, but of course you have to be aware that you first of all need a good bioinformatics to really look at that, a good databases to find out which kind of mutation is really relevant and which is not, and you should be able to do a CNV calling from the whole genome sequencing data, and then be aware that you still don't find all the cases. Especially I think that. But you don't find, especially the inversions and so on, you don't find, So the cytogenetic complicated findings you will still overlook. But I think if it's becoming cheaper, I definitely would go for whole genome sequencing from the scratch, and even in actually in all neurodevelopmental disorders, because also I think, and you have heard this. I think studying polygenic risk is also relevant, and we have not included this in our genetic counseling pipeline. And I know, for example, from human geneticists who do counseling on breast cancer, that they currently really look into mutations plus polygenic risk for breast cancer to predict the prognosis. Is it likely to have breast cancer based on this mutation or not? And I think this will be exactly similarly relevant for mental disorders. But this is a long way to go, because it's not in the healthcare system established, not at all. And we lack, of course, people with the bioinformatic knowledge to do all these kinds of analyses. So this is not that easy. Probably in India, you're better off with bioinformatics than we are in Germany, but still, I mean, you need to have a good competence on bioinformatics to really look into all these data you generate then,
Thank you very much. And do you think in the future the classification of an ASD would be largely molecular, now that we understand more about the genetic mutations and the life course of those individuals with very specific mutations?
You think intervention, if this will be molecular, the intervention?
That's it.
I'm not sure. I mean, I think even in cancer research, I mean, you have, but there you have, yeah, sometimes you can do something, it's true. It's very hard, I think, for autism, or especially for all mental disorders, because they are brain related, and it's of course much easier to find biologicals for skin disorders, because you can always do pathology on it, but you cannot do brain biopsies, yeah. And so it will be a very hard way until we have really biologicals. But what I think what is easier and what we could achieve is to do to screen existing medications in relation to the biological background of the children, and see, yeah, which would be the more effective ones and the less effective ones. This is probably doable. The biologicals, I mean, maybe in 50 years, but not in the next 10 years, probably not. Yeah.
Thank you. Thank you very much for the exciting talk.
Yeah. We have a couple of questions. Most have been answered so far. There's one question from Dr. Leena, who says, currently in the UK, we have an intellectual disability gene panel, but not ASD panel yet. And often it seems to be more epigenetic in the families we have seen. Hence, I would be interested to know if you have an ASD panel or you do whole exome or whole genome sequencing, because in NHS, whole genome sequencing is still panel based. It is complimentary for your talk. So the question is whether you do have a ASD panel, and you do ASD panel and directly go with whole exome or whole genome sequencing.
Yeah, I can answer that if you want.
Yeah.
So the preference is always test more genes, and will provide more information, especially, you know, depending on what state you're in. There's not a huge cost difference between a chromosome microarray and an ASD panel compared to the cost difference between whole exome sequencing and CMA, which is relatively more significant. So instead of waiting for one panel to then yield no results and then escalate to a chromosome microarray, it's always advisable to do CMA over an ASD panel. One, for there's more genes involved. Two, it just elongates the time the families are waiting to gain some answers.
Thank you. I think most of the questions have been taken up. We'd like to go with the case presentations. I would request the first presenter to share the screen and present, Dr. Elif from Turkey.
Good evening from Turkey. I want to thank to my mentor, Professor Dr. İlknur Erol and Hasan Tekgül, and thank to the organization committee to give me a chance for this presentation. I will share my screen. This night we present a 9-year-old male. He was admitted our clinic at 9 years old. His initial complaint started at 4 years. He had difficulties in communicating with intimates, temper tantrums, and followed 3 years nearly by child psychiatrist with diagnosed selective mutism. He had taken special education and play therapy. He had good at school and poor maths performance. Risperidone was initiated by psychiatrist. He was admitted at another clinic, and he had an EEG, and there is an epileptic anomaly was detected. Drug suggestion, but the family don't use the drug, his medication. Here you can see him. He don't want to make eye contact, but he was answering the questions. His school performance is a little bit poor. He had no unremarkable history, and her parents were non-consanguineous family. In his laboratory, only vitamin D decreased, and it was replaced. In his basal metabolic analysis, we performed, and there were no unremarkable. There were no there's no remarkable results. In his EEG, you can see the spikes waves at centroparietal hemispheres and bilaterally. In his MRI, there was no specific findings. In his neuropsychiatric evaluation, in his WISC-R tests, he had a total point 64, and he was resulted with much MRI. Especially the psychologist noted that his verbal skills and visual spatial motor skills developed differently, and genetic analysis and other tests were suggested. We analyzed, he had no dysmorphic findings, so we performed genetic analysis with whole exome sequencing. In his USP9X gene, we find the hemzygote novel mutation, and this was reported in the literature in uncertain clinical significance. This disease shows X-linked inheritance, so we plan to analyze the family, especially mother, and there were no pathogenic alteration detected in his mother's analysis. With his intellectual retardation, silent ACD findings, and EEG findings, we thought that he had the de novo USP9X gene, the novel variant, and it can be related with intellectual development disorder non-syndromic form. So we investigate the literature, and we saw that this gene is related with protein degradation and signal transduction and escapes X inactivation. Especially in the literature, there are lots of female cases with this gene related. And in here, this review, we saw that in males, this gene can be related without multiple congenital malformations and ACD phenotypes. And in some males, there can be epileptic forms, and especially it's very important for us in this article for 2 de novo mutations reported in the large autism course, and no specific gender information was described in this literature article. And the investigations increases. There were some dysmorphic males related with this gene, but in our patient there were no dysmorphic features. We thought we have to confirm about the genotype phenotype relationship with this EEG analysis. So we analyzed the literature. So we saw that in the literature, prickle interactome molecule and USPX gene related in the pathophysiological pathways with the seizures or EEG findings. So we thought that this gene can predispose on for the seizures. At last, we thought with our patient, he had an intellectual disability, ACD findings, and abnormal EEG findings. So we thought this is a novel variant and de novo mutation. So we accepted the patient USP9X related intellectual development disorder non-syndromic form. Thank you for listening to me. My presentation is that's all.
Thanks for the presentation. I'd like to invite comments from Christine and other experts.
You asked for a comment by myself, yeah. Yeah, I think that this is really interesting, and of course, I mean, you cannot prove that this is definitely 100% related to the autism diagnosis in this child, but it's an interesting aspect, and I think you have did a very good literature search to look up what kind of single case descriptions we have already reported, and I think there definitely are X chromosomal bound cases of autism spectrum disorder. So I personally would also say it's probably not unlikely, but I must say I have learned from human geneticists that you should not be too over optimistic that you have found a cause for something, because maybe research will sort of result in different results later on. But still, of course, I mean, you have found something, and this child has an unexplained disorder, and what is at least reassuring is that the mother doesn't carry it, and so if she still wants to have a second child, she is not transferring this kind of mutation to a second child. So this is quite important, I think. Yeah.
Thank you, Professor.
Coming to other experts.
Mahesh.
Yeah.
Professor
Mahesh,
Irol,
I'm
Professor
yeah.
Irol.
Yeah. Thank you, Shefali. Thank you, Mahesh. Thank you. Congratulations, Elif. I really enjoyed your presentation and the interesting cases. This is a typical example of, I mentioned that after the Christina's talk, these cases use the two different networks, autistic networks and then epileptic networks together. So in our practice, every day, I choose a gene, or I see a results of the gene results, and then I put in the my side, and then I read the papers. What is the novel cases, and then what can be do for these cases for a precision therapy, something like that. So I think we have to be familiar this kind of presentation. So we extensively use the genetic testing, but also İlknur also mentioned that we in Turkey we use a step-based approach. First step is the clinical phenomenology with using the genetic test. Second step, metabolic screening, and then third step is the neuroimaging. Finally, we goes to the genetic testing, and then diagnosis came out. Congratulations, İlknur. Congratulations, Elif. I really enjoyed the case. Thank you.
Thank you. This case is very interesting for us also because when we check the literature for this gene, we see that the ubiquitin system is an important system for autistic spectrum disorders and intellectual disability. And also, this system is important for seizure. And also sometimes these genetic mutations in this gene can be related with the cortical abnormalities, to some migration defects. So since the mother is normal and the gene is de novo mutation is de novo mutation, and we cannot find any other things for explanations of both the EEG abnormality, learning abnormality, and the slightly autistic spectrum disorders. We thought that this mutation can be explain the clinical findings of our patients. And maybe in future, most of the cases with this mutation can be added to literature, and then the pathophysiology can be understood. After that, maybe the targeted therapy for this abnormality may be find. So it is very surprising for us to find this abnormality. Thank you for Elif and all the others for their comments.
Yeah, it was a beautiful case, and I'll tell you why I found it especially beautiful. So we already know a much more famous or known syndrome that affects the ubiquitin pathway, right? Angelman syndrome. And we know kids with Angelman syndrome tend to have an increased risk for autism and epilepsy. So even though it's a slightly different gene, it's the same pathway that's involved, right? So it gives that beautiful spectrum that we were talking about, that as we learn more and more gene involvement, what can we pull under certain umbrellas? So great job.
Thank you.
Dr.
And
Vinod,
the next
Dr. Mainak.
presenter-
Dr. Vinod, Dr. Mainak. Dr. Moinak, Dr. Vinod, anything you want to add?
No, thank you very
Vinod?
much. Thanks for the next presentation.
Next case.
Request Dr. Edwin to share his screen. Dr. Edwin.
Sir, can you hear me?
Yeah. Share your slides.
Just give me a moment, sir.
Yeah.
Even if it's going to take long, we can do the third case first because we
yes,
are already near
yes,
closer.
yes.
Can you have the third case first? Yeah, please.
Dr.
Yeah.
Achanya?
Yes, sir. I'll
Yeah,
share my screen.
yeah, you can do that. You can make it full screen.
Yes, sir. I'm making.
Chanya, 5 minutes, please.
Is my screen visible?
Yeah, it's visible.
Good evening, all. I'll be presenting a case of a child with autism and myoclonic atonic seizure from AIMS Rishikesh under the guidance of Dr. Pratik Kumar Panda. We have an 8-year-old boy, a Master P, resident of Bareilly, UP, under follow-up in OPD, presented with the complaints of language predominant delay, abnormal body movement since 3 years of age, and poor eye contact since 3.5 years of age. He presented to us at 8 years of age with language predominant delay. At 3 years of age, he had myoclonic atonic seizures around 1 episode per day to 2 to 3 episodes per day, for which he was evaluated outside, and the seizures were controlled with anti-seizure medications. He's currently off anti-seizure medication. At 3.5 years of age, he developed autistic features in the form of poor eye contact, poor social interaction, stereotypies, aggressive behaviors, and self-injurious behavior. He did not have any motor regression or any drooling of saliva associated with it. The birth history was non-contributory. The family history, he was born to a non-consanguineously married couple with no history of any seizures or autism in the family. On examination, the child had a normal anthropometric measurements with large yes on examination, but no other obvious facial dysmorphism or other dysmorphic features, and no neurocutaneous markers. He had moderate autism as suggested by a total CAR score of 37 and ISA score of 120. So the differential diagnosis considered in the child in view of epilepsy, language delay, and autistic features were single gene disorders like CHD2, SYNGAP1, ST, XBP1, CDKL5, KCN82, FOXG1, and SLC2A1. But the child did not have any dysmorphism or any microcephaly as seen in few of these disorders. So the other differential considers were chromosomal disorder like Angelman syndrome. But there's no dysmorphism or microcephaly as seen in Angelman syndrome. Other differential consider was creatine deficiency disorders. However, the child did not have any movement disorder.
I know.
The other differential consider was ESES in view of
Yatwin, please
features.
mute
I just
yourself.
added the
Yatwin, mute yourself.
publication page, sir.
Yatwin, please mute yourself. Yeah, please continue.
So
Achan.
the last differential considered was ESES in view of autistic features, aggressive behavior, and seizures. However, the child did not have any significant motor regression as is seen in ESES. So MRI brain was done at 3 years of age, was normal, and the sleep EEG was done at our center, was normal, and it ruled out ESES. So we went ahead with genetic studies. A chromosomal microarray was done, which was normal. However, the whole exome sequencing relieved a heterozygous gain of function mutation in the exon 6 of SLC6A1 gene inherited in an autosomal dominant pattern. The segregation analysis was performed in the parents were negative, hence a de novo likely pathogenic mutation of SLC6A1 gene consistent with the diagnosis of SLC6A1 gene-related neurodevelopmental disorder was made. The child was started on risperidone, ABA, speech therapy, sensory integration therapy, and the parents were also advised regarding TEACH program. The initial CAR score was 37, which reduced to 33 after 6 months of follow-up. So few words about SLC6A1 related neurodevelopmental disorder. It is caused by an aberrant GABA neurotransmission secondary to impaired function of GABA transporter protein. They usually present with developmental delay, epilepsy with myoclonic atonic seizures, autism, and motor dysfunctions, including stereotypies and ataxia. These are the most common clinical features. So a draft conceptual model of SLC6A1 related NDD is described in this paper as it is projected. So the developmental delay and behavioral problems along with epilepsy also has a significant impact on the daily life activities in these children. However, as more patients are diagnosed with this genetic disorder, the spectrum of severity is widening. So I'll like to end with a take-home message of, in a child presenting with predominant autistic features and history of myoclonic atonic epilepsy, we must suspect SLC6A1 related mutation. Thank you.
Dr. Pratik?
Sir, I just want to highlight one small thing, sir. In this case, we usually suspect SLC67, but we need to also rule out other genes we suspect. CHD2 is more common in such cases. Other cases of SLC67 in our institute, which have previously, they have mainly epilepsy. Autistic feature was less severe. In this case, sir, the epilepsy was passive even without much treatment. So I was kind of skeptical because it was a VUS, variant of uncertain significance. But then we studied the literature and we find out that now there's a new name, SLC67 NDD. So we thought it could be a matching, and it was also de novo variant also. That was the.
Thank you, Pratik. I'd like to invite comments from the experts. Professor
Maybe I
Christie?
can comment. I think it was a very nice presentation. What I would be interested in the anti-epileptic medication, because probably it was really very well targeted towards this mutation. And just to comment on the comment before me, I guess that's the additional either polygenic or maybe prenatal biological risk, which then maybe really also cause the autism in this child with this kind of mutation, in addition to the epilepsy. But we will never know. I mean, this is hard to study, but it's probably, there probably are additional risk factors for the autism. Yeah, but the anti-epileptic medication would be of interest. Do you know that what the child received?
Ma'am, the seizures were actually 3 years back. The doctor has prescribed most probably valproate, but the parents were a little bit of a lower socioeconomic status. But so how many months they continued? They started the medication, but we don't know the exact compliance because it was started by some other physician 3 years back. They presented to us mainly with autistic features with a history of myoclonic atonic seizures, ma'am.
Okay.
So it was, the drug was valproate, but we didn't exactly know how many months they did continue. That's my.
Risperidone did not result in a recurrence of the seizures.
Ma'am, we are
Risperidone, because sometimes it lowers the seizure threshold, and sometimes you then will have seizures again. But with the risperidone, the child took it well.
Ma'am, we initially did the EEG, and when we thought there was not much records, any discharges, so we initially thought of starting aripiprazole in this case, but there was too much aggressive and self-injurious behavior, and even I have mentioned one possibility of Lestinian in the genetic testing report. So we thought risperidone will be better, and there was no recurrence of seizures after starting risperidone, ma'am. But my first choice was to start aripiprazole. But when I didn't get anything in the EEG, so I thought there might not be recurrence after 3 years.
Mm-hmm.
Thank you. Thank you, ma'am.
Thank you. Yeah.
Yeah. So just 3 points, right? Kind of the congruity of my comments have been, we're shifting towards saying names such as related disorders. And this is exactly one gene that they're starting clinics, especially in the Northeast of America, and it's under the related disorders clinic. And the second thing is, this gene affects the GABA transporter. So I don't know if you've done literature study on this, but it would be really interesting to see if anti-seizure medications that act on the GABA receptor, do they worsen seizure frequency or do they improve seizure frequency? Because they would probably have a very different effect to seizure medications that don't primarily act on the GABA transporter, right? The other thing is, this is one of the genes is getting a lot of importance in preclinical studies in terms of gene therapy. So there's a lot of excitement here in the US with preclinical studies in mice showing that gene therapy had an effect on epilepsy. And so maybe in a couple of years, there'll be a gene therapy for this one.
Thank you. Hassan, any comments?
Yeah, I really enjoyed the case. This is a typical case of developmental epileptic encephalopathies in early life. The etiology-specific diagnosis is really important. The gene name developmental epileptic encephalopathy. When we are trying to define the gene, sometimes we underestimate the electroclinical syndrome definition in this kind of case. In the future, maybe we will see the typical electrophysiological findings, and then we maybe try to use anti-seizure medication based on the electroclinical syndrome definition. Which kind of syndrome may be developed in the future, EEG will explain to us. Today, we choose the drug based on the seizure semiology, and sometimes we use it based on the TUBA also. Kristen mentioned that based on the gene diagnosis, gene-related developmental epileptic encephalopathy. I would like to state that we don't omit the electroclinical, electrophysiological diagnosis of the cases. Maybe case diagnosis of EMAS, maybe diagnosis of, in the future, ESES, or any different kind of electroclinical syndromes. Sometimes we use syndrome-based therapies, steroids, something like that, additional to the anti-seizure medication. Thank you.
Thank you, sir. Should we move to the third case? I request Dr. Yatvik to share his slides. You make it full screen, okay? You can go ahead.
Can you see?
Yeah, we can see your slides. You can go ahead.
Thank you. My name is Yatvin. I'm a MBBS intern in Sri Ramachandra University. Under the guidance of Dr. Ranjit, I will be presenting a case under the title Distinct Facial Dysmorphisms in a Child with Autistic Spectrum Disorder. Clinical presentation: a 9-year-old boy presented with signs of global developmental delay and symptoms suggestive of autism. He was of non-consanguineous parentage, and his antenatal and perinatal history were uneventful. Anthropometric measurement showed stunting as well as microcephaly, head circumference of 47 centimeter. He had no other significant medical or surgical history, and no similar complaints were reported among family members. On examination, inspection showed presence of hyperteloism with deep set eyes, and more prominently, outwardly prominent and low set cupped ears. He also had a bulbous nose and elongated face with the presence of microcephaly, as I mentioned before. And the region between the nose and the mouth was also much smaller in the form of a thin philtrum. So, based on the dysmorphism, we were thinking of a syndromic cause for the autism. MRI brain showed a normal study, and clinical history of facial dysmorphism made us think in the sense of genetic causes. So we sent the clinical exome sequencing, which came back with a report of pathogenic hemizygous deletion in the exon 5 of PQB1 gene, which is the polyglutamine track binding protein 1. So the above hemizygous deletion was pathogenic. Excuse me?
You can go ahead.
The above variation was pathogenic for Ren-Penning syndrome. So, discussion. Ren-Penning syndrome is an extremely rare X-linked recessive genetic condition associated with PQBP1 variations. So, the condition is consistent with a short stature, microcephaly, intellectual disability, and dysmorphic faces consisting of elongated faces with upslanting palpable fissures, bulbous nasal tips, and overhanging columella, short philtrums, and cupped protruding ears, as we saw before. And there's also presence of microorchidism. Congenital cardiac anomalies such as atrial septal defect, VSD, ventricular septal defect, or tetralogy of Fallot may also be seen. Muscular atrophy involving paraspinal muscles, which may also manifest as scoliosis, may also occur. They also report cleft palate and anal malformations such as imperforate anus and ocular colobomas. These are seen among 20% of the patients. Management usually involves early intervention through speech and behavioral therapy, special education, and treatment of associated symptoms, such as the cardiac defects and ocular colobomas, as I mentioned before. To our knowledge, based on literature review, this is the first reported case of a Ren-Penning syndrome in a child from Indian population. There is one reported case on an adult in India. So, as a take-home message from this presentation, the report seeks to highlight the importance of looking for specific facial dysmorphism among patients presenting with features of autism to make a more precise and etiologic diagnosis, which may have a great impact on their prognosis and antenatal counseling to the parents. Thank you for the presentation. We have a report
Ranjit, your
from-
comment?
Yeah. Yes, sir. Can you hear me?
Yeah.
Yeah. So thanks, Yadvin. So we presented this case just to highlight, like in a child with autism or intellectual disability, we should spend at least a few minutes looking specifically at the spatial dysmorphic features, because that was the clue towards ordering a whole exome sequencing in this child. And to my surprise, I saw this syndrome, which I heard for the first time. And this is the first report of this Ren-Penning syndrome from an Indian pediatric patient. So I think it's very important we look for soft clues like dysmorphism. Thanks for opportunity.
Thank you. Comments from Dr. Naser?
I'll tell you what, I'll request all the experts to give the comment on this case and their take-home message. Professor Christine had to leave for another appointment of hers, so we have all the others to make their final comments along with any comment on this wonderful case which Ranjit got to send. Professor Hassan.
Yeah, thank you, Dr. Shefali. Thank you. Nice presentation. I really enjoyed the cases. I remember my memory from Chennai 3 years ago in the Congress. This is, I think this is a really interesting case and typical case for the indicating the clinical phenomenology is important step. So I think we use this clinical phenomenology, then we try to define which gene which genetic testing modality we use the cases. Why they used before the whole exome sequencing, they did define any single gene analysis or any specific genetic testing before the whole exome sequencing to identify any possible diagnosis. What is the first clinical initial diagnosis based on the facial dysmorphology? Yatin.
Yeah. Yes, sir. Can you hear me?
Do you have a clinical possible diagnosis before the asking the whole exome sequence?
Can you hear me?
What is your initial diagnosis? This is the final diagnosis. Any other differential diagnosis cases?
Yeah, yes, sir. That's a good question. Can you hear me, sir? Yeah.
Yes, I can hear.
Yeah. So he did not have macrocephaly or macroorchidism or other features. So we didn't keep Fragile X as a differential diagnosis. Instead, he had microcephaly. He did not have this happy puppet or like a happy personality or even some other personality to suggest angel man or Prader-Willi like phenotype. So so we didn't have any specific syndromic diagnosis, but we kept most likely a possible underlying syndrome or a non-syndromic autism with intellectual disability.
Great.
Yeah.
Yeah, great. Thank you very much. Clear explanation. My final message is, Dr. Shefali, it was a great session for us for the genetic testing and autistic disorders. So we discussed about the utility of genetic testing for differential diagnosis as well as therapeutic aspect. Thank you very much for Dr. Christina and all the panels and the presenters. I really enjoyed the webinar. Thank you very much.
Thank you.
Thank you,
Thank you.
Dr.
Thank you, Professor Hassan. Dr. Tuba had to start her clinic, which was there because the session was getting late. So I have
Mhm.
Dr. Vinod who has to give their take-home message. Dr. Vinod Skaria and Dr. Moinaf also had to leave. So Dr. Vinod,
Yeah, thank you. Thank you very much.
take-home
I
message.
think this entire session highlights the importance of two things, doing the clinical phenomenology of great detail, and second, doing genetic testing great great depth. And combining both of them hopefully can benefit patients in a big way. Thank you very much.
Thank you, Dr. Vinod. Professor Irol, your final comments?
Thank you for all presenters and you and all the other doctors for their important comments. I want to make a new comment because we know that the autistic spectrum disorder is high in male patient. In two presentation, we saw that the X-linked disorders, the one and the third presentation was due to the mutation in X chromosome in male patient. So I think the X chromosomal abnormality is more seen in autistic spectrum disorder. And in the third presentation, according to my opinion, we will start with chromosomal analysis and microarray analysis. Firstly, because of the dysmorphic findings and the microcephaly. If we see that these tests is normal, after that, whole exome analysis may be more useful, I think, according to my opinion. In fact, I want to ask Christina for her comments, but I want to say and thank you for you and all the presenters.
Thank you, Professor Irol. I thank you. All the presenters presented really well and their mentors. And I welcome you all to the 17th AOCCN, which is going to be from 16th to 20th of September this year in New Delhi, Yashabhumi. We will be having 8 pre-conference workshops, including autism. And then we have 4 whole days of wonderful scientific sessions and then a post-conference workshop. So all the registrations are on, abstract submissions are on, symposia proposals are on. So I invite you for the same. And all the presenters will be sent their certificates. Mahesh, you want to say something before we wind up?
No, it was a wonderful discussion on genetics of autism spectrum disorder. In our country, because of the state doesn't sponsor this test, most of the times the parents or the patients have to bear the cost. That's one important drawback what we face in our country. At the same time, the testing is a bit cheaper in India. That's another advantage what we have in India. So for epigenetics, as of now, we do not have much of testing in our country. I think there should be some studies on genetics also.
No, I think genetics and epigenetics both are very important in autism, and I think epigenetics may have give us more therapeutic intervention targets and something which can be modifiable. So I think we can end today. Thank you so much, and we join us back on 29th for a session on Rasmussen's encephalitis, the current update on the same, and I welcome you all to New Delhi again. And I think the video will request, Asmita to run the video. Thank you very much, everyone. And looking forward to meet you all in New Delhi in September. The video, please, Asmita.
Okay.